question. Oh, I love it. See? Oh, good, good, good. All right, I'm going to run around. Just a quick question. If a treatment's working, which was initially topical steroids and light therapy, but as soon as it stops, it's coming back, can you continue that treatment with no really major side effects long term?
Bob, that sounds like an early disease question.
You can continue for quite some time. Would you agree?
Yeah. Any other thoughts? Those are fairly low toxicity therapies.
I think we try to use as much as we need, but try to find that balance between not giving more than you need, because even topical steroids, I have patients where if you're covering your body in it every day, we do see skin thinning, and especially as you get older, the skin thins on its own, and just as a natural part of aging and from sun exposure. And if you're getting skin tears and you're bruising all over your arms and legs and you're all cut up, then we have to balance that. Same thing with ultraviolet light. It can be great. You can do it for a long period of time. We can reduce the frequency to sort of just what we need under control. A lot of times the condition will come back if you stop, although usually it will work again if you restart. But if you're someone who's getting, say you've done PUVA particularly in the past, or you've had other things, and you're someone who gets a lot of other skin cancers, squamous cell skin cancers, then we have to pause and say, okay, is this the best thing, or are there things we can do to mitigate the risks of that treatment, even though the risks of the topical steroids and the phototherapy are less than, say, systemic chemotherapy.
And I think one thing to point out is also always defining what do we mean when we think it's not working, right? Because I think we on the provider side may sometimes think, okay, we just want to keep things under control because there is no definitive cure. But if we keep things stable, and even stable means it may flare during some weeks and then it goes down. But if that amplitude around sort of a baseline, if we keep it under control more or less, then we usually tend to not be more aggressive and add too much more on. Yeah.
One important thing that, and I'm not sure that all people that treat CTCLs subscribe to this, but I've certainly found it to be true in my own experience, is that it's very important that you don't stop phototherapy too abruptly. So what I usually do is, normally people are, when you're trying to clear them, they're on 3 times a week. And if they clear, then I take them down to twice a week, but I won't change that for at least a month to make sure that there's enough time for them to break through if they're going to break through. And if they do, then I go back up to 3 times a week. But if they stay clear on 2 times a week for a month or more, then I'll take them down to once a week. And for once a week, I'll keep them on that regardless of what they look like for, I shouldn't say that, assuming that they stay clear for a minimum of 6 months, once a week, up to 2 years. And in my experience, that doesn't prevent you from having a recurrence later, but the recurrence or the relapse-free period will be significantly prolonged. So in other words, instead of having a relapse within a few months, you might have a relapse, but it might take a couple years for that to happen. So that's one thing. The other thing was that, I think, Bob, you were talking about treating 1A disease and said nobody is really, or no one's ever going to have 1A patients with no treatment and then 1A patients with treatment. Actually, that has been done informally. There was a guy up in New Hampshire at Dartmouth, Bill Benning, who did that with his 1A patients, and he had about a couple dozen of them that he didn't treat with anything other than some at that time, there weren't even the high potency steroids. This was many decades ago. And he said, just treating them with something like Triamcinolone, which is a medium strength steroid, which some of them did consistently, some of them did on and off, some of them didn't do anything. That in the group that he followed, just a few of them went on to something worse, like stage 1B disease from stage 1A disease. And that's sort of borne out in the Dutch. The Netherlands is such a small country that you never lose anybody to follow-up. And so they have like 20 years survival data on early MF. And although there are some people that progress from stage 1A to 1B, and we really don't know how to pick those people out yet, by and large, the 1A stayed 1A in that study. And with this older stuff that, and I think Bob's correct, that'll never be done for medical legal reasons as well as for other practical reasons. But at least in Clendening's experience, the people that he elected not to treat did just fine.
Okay, I have a question about the thing you mentioned about the thymus gland. 75 years ago, 6 months after I was born, I had radiation in the thymus gland. Okay, then in the 70s, they did a recall and they found nodules in the thyroid. And is this any tie-in with MF, which I've had for 30 years, or diagnosed with 30 years?
That would be a very hard one to answer. I don't think what happened to your thyroid would have any bearing. In terms of the thymus, there probably is still some activity going on after 6 months, but I think most of the work of the thymus for most of the lymphocytes in a person's body is probably largely done by then. So it would be hard to say. And also, I think, as was pointed out earlier, problems with the thymus would be more likely to lead to immune deficiency diseases, I think, rather than you know, an overactive type of a clone like a cutaneous T-cell lymphoma.
In phototherapy, if burning happens within 20 seconds, is a concern? Like, you just keep going and because the skin burns very easily under phototherapy after 20 seconds.
If depending on the dose, it might be better to find a different skin-directed treatment if you're that sensitive to the light.
And I was just gonna go ahead, Carrie.
Sometimes for redheads and such who really don't tolerate a lot, you can cut way back and try really low doses, much lower than we would typically start for people. But sometimes there are people who have other reasons that they can't do phototherapy in connection with medications, or there's people who have these allergies to ultraviolet light that makes it really difficult to use it. So sometimes we can try really tiny doses and cut way back and go very, very slowly. And sometimes we have to find something else.
And I will just mention that there is a current clinical trial that's using fluorescent light that we hope will be, we'll see that the trial is finishing up. So it wouldn't have that same kind of impact as the other UVA, UVB treatments. So it's a little bit of ways yet. We're probably at least a year before it gets submitted to the FDA, but that's coming down the pike, which should be helpful for people that are more sensitive to that. I'm going to ask a question from our live stream audience, and I'll go back over there. And then I know Sheila had a question. Is lymphomatoid papulosis and MF linked? Question.
I'll start. We do see, so patients who have lymphomatoid papulosis are at a higher risk than other people of developing another form of lymphoma. The types of lymphoma we see more commonly in those patients tend to be mycosis fungoides, anaplastic large cell lymphoma, and Hodgkin lymphoma. So yes, they are linked together, but the risk is still quite low. I think people with lymphomatoid papulosis have about a 10% risk of developing another lymphoma.
The other thing, we've talked a lot about clonality, and in at least some cases where lymphomatoid papulosis and mycosis fungoides have occurred in the same patient, the T cell clone in both of those lesions is the same. Obviously, the clinical disease is different. So rather than being exactly the same clone, probably one of them is a subclone of the other, but at least in some cases, they do share the same T cell receptor, indicating that they probably arose from the same cell at one point in the history of the patient.
Some years ago, I was given methotrexate. This was prior to my SS diagnosis. I was given methotrexate to treat rash and skin discomfort, and it was not effective. Was recently then now just told a good treatment plan would be for me to begin the total skin electron beam therapy, but not with methotrexate because it had failed in the past. Can you comment on if that would be a good reason not to be using that drug just because it was sort of a single agent at the time? I don't know if that makes sense. It's kind of a long-winded question.
Yeah, so I think the question is what exactly was treated back then, right? Was that already Sezary syndrome or not? If it was Sezary syndrome, you could, in theory, and this is really just sort of basic oncological practice, we tend to think, a treatment failed once, even if it was years ago, usually that doesn't get restarted. But in theory, it could be that the disease has changed so dramatically that maybe methotrexate would work at this point. What usually people do not combine is radiation and methotrexate. We have a lot of patients where basically whenever we send somebody for radiation, we hold methotrexate. And if we don't do it, the radiation oncologist is doing it, because we are just trying to minimize the risk for skin damage, skin breakdown, which would then really be a portal for infections and everything. Yeah.
One last point I'll make is sometimes we have to be very careful about when we will call something a failure, because sometimes we don't give it long enough or a high enough dose. And so without knowing the specifics, methotrexate can be a great drug. It's not a fast drug. So if you were on it for 6 weeks or 8 weeks, that may have not been long enough to tell if it's going to be helpful. And it will depend a little bit on the dose that was used too. So sometimes in dermatology, for other skin things, we use these very low doses, 10 milligrams a week or things like that. Sometimes we can push the dose higher for these conditions and see that maybe 20 or 30 milligrams will work where 10 would not. So I think there's some nuance to deciding if something has failed or not too.
Yeah, I think that's true with all the drugs. So if people come to a cutaneous T-cell lymphoma center with a history of failing, a few therapies, you really need to delve into the details and find out how they were treated, because a lot of dermatologists in the community, when they start somebody on, say, narrowband UVB, will only give it to them 2 times a week. That's not adequate for treating MF. At least in most cases. If you're trying to induce a remission, you need to start at 3 times a week. And if you've never had 3 times a week, you haven't really failed. You've just not been treated with an adequate regimen.
I actually have tons of questions. My first question is, well, let me start by, I was diagnosed 8 years ago. 6 months I did phototherapy. I did a panning, what I call a panning booth, looked like a panning booth to me. And 6 months later, my CD4, CD8 ratio, which originally was like a 3.89 to 1, went up to like a 7.2 to 1. And so my dermatologist at that time said, okay, I'm going to introduce you to the oncologist, the BMT team, bone marrow transplant team. And we started photopheresis. I have been on photopheresis since then. Photopheresis is the only treatment I have. I, of course, always have Triamcinolone on hand if and when I need it, but I'm hearing that there are double therapies. So, and I don't get a double therapy. And my skin is clear. Even when I started photopheresis, my skin was all clear. It was that CD4, CD8 ratio that, motivated my dermatologist to recommend photopheresis together with the oncologist. So I guess that's my first question is, do I need to be going back to my healthcare team? Because I have a pretty good relationship with them.
So yeah, fantastic response, right? And even though I said oftentimes we combine photopheresis, but ideally, if the disease isn't strong enough or severe enough, it's actually great if we can try it as a single agent and can add on as needed. I think in your case, your question is well taken, right? How much of it is needed at this point after so many years on the photopheresis, and in fact on lots of these treatments, sometimes we can induce what we call remissions and very durable remissions. So the question is, would basically anybody involved in your care probably has the same question: how much at this point is the photopheresis still needed, or could it be time to maybe come off of it, and if the disease comes back, maybe treat it differently? But these decisions are always really hard to make, because if something comes back, then it may also behave differently, and what keeps it at bay and actually not under control, but in remission at this point may not work that well the next time around.
But in January, we're going to be looking at 2 treatments every 12 months.
Yeah, and I think that's reasonable, right? And like Dr. Wood said, I think many of the medications, that's true for methotrexate, for a lot of these things, in addition to the light treatment, we like to taper. And then if the taper is successful, if taper means we decrease the dose, and if clinically nothing comes back, then, well, we can maybe get the patient off certain treatments.
If you have a diagnosis of Sezary syndrome, do you think symptom relief is a reasonable treatment goal?
Absolutely. I think one of the things that's most debilitating for Sezary patients is the itch and just skin discomfort. I think now we have many better agents than we've had in the past for treating Sezary syndrome, because oftentimes what we really need to do is control the disease to control the symptoms, and that's not always easy. But even as we're working to find a regimen that works, there's topical things, there's radiation, there are oral medicines to help with itch that we can use to try to make people comfortable and able to do their normal activities of daily living.
If someone is diagnosed with both LYP and MF, is that highly concerning, and what are the chances of it changing into another lymphoma?
It is definitely something that we see. Like I said, patients with lymphomatoid papulosis will often, about 10% may develop a second different type of lymphoma. The mycosis fungoides, prognosis for that is going to depend on stage again. So the two together does not necessarily have a worse prognosis. And lymphomatoid papulosis is not considered a life-threatening condition. So I think prognosis would be dependent on the stage of mycosis fungoides.
Yeah, and then if two of those two are present, I'm not aware of any data suggesting that increases your risk to get the third one, for example, Hodgkin's disease or endometrioid cell lymphoma. Yeah. So answer is it wouldn't be, the combination wouldn't be more concerning depending on the stage.
Yeah, and the other thing is that in terms of their response to treatment, often people who have lymphomatoid papulosis and MF, both one type of disease can respond to whatever treatment they're on, and the other disease will just go its merry way. So, and that often happens when you're treating, because the lymphomatoid papulosis is considered a clinically benign disease, even though it can be troublesome. The focus is usually on treating the MF, and the MF can go into a nice remission, and the lymphomatoid papulosis is completely unaffected. So it's proof that from a biological standpoint, they're behaving as different diseases, even though there is evidence that, at least in some cases, they arise originally from the same T cell, same parent T cell.
I have a question about the total skin electron beam therapy. What does that really do? Is that a good long-term therapy? And if so, what is the effect on the skin?
I can take the start, I guess. So for certain types of lymphoma, for certain types of mycosis fungoides, it can be very effective and it can induce a remission. However, we tend to use it more for sort of more advanced disease. So often people with tumors or very widespread plaques, sometimes the plaques that are breaking down and ulcerating, it can work very well. It can be given in different doses, and sometimes the side effect depends on the dose that's given. So historically, people used to give very big doses of radiation, and then people would lose hair permanently. They'd be unable to sweat. They had more risk of other skin cancers down the road after it. And unfortunately, the other thing is, like in any of these treatments, it tends to have a temporary effect. So oftentimes you need some sort of maintenance treatment after it or some sort of follow-on treatment.
But any recommendations for Sezary versus MF?
Well, in my opinion, much of the problem in Sezary is these cells that travel between the blood and the skin. And the radiation will only be effective at killing off the ones that are in the skin. And that the problem is really what's circulating in the blood. And so it is not usually my starting point for people with Sezary syndrome, but I don't know if.
No, I agree. And that's why I wanted to make a point showing these skin resident cells that give rise to mycosis fungoides versus the other ones that really like to travel back and forth. Because you could envision the scenario that you basically effectively kill all lymphoma cells in the skin, and maybe the total skin electron beam would do that. But then you have these cells hiding in the lymph nodes, hiding in the circulation. They repopulate the skin. And I mean, in fact, that is one of the problems we have, that we call that compartments of disease, or you can think of those as really buckets where these cancer cells live: skin, lymph node, and blood. Most commonly not in any other internal organs. But there's communication between these compartments, communication between these buckets, and some of our treatments effectively kill down to the level that we can't detect cancer cells anymore, for example, in the skin, or more commonly in the blood. But the disease is still not cured because cancer cells evade in niches in the skin, in the lymph nodes. So that's why it's always important to keep in mind that, which compartment are we targeting? And for Sezary, since we know that the disease lives in all three compartments, only targeting the skin is probably would be just incomplete. So I think that has something to do also with the dose. The answer a few years ago probably would have been you don't repeat it, because we used a very high dose. With those low dose and even more coming up, even lower dose regimens, maybe you can do it.
There were very few people that had it more than once, as Dr. Scheike said. Recently, among radiation therapists, there's been a tendency to reduce the dose for all types of ionizing radiation therapy to the skin, not just total skin electron beam. So with these lower doses, it would be possible to probably have it twice. Beyond that, it would really depend. But in the past, very few people were treated more than once with it. And it is not, it's rarely a cure. You can have dramatic results. MF cells are extremely sensitive to ionizing radiation. If you radiate any spot of MF, you'll almost always make it go away. But if you don't get all the cells, which you don't, they will grow back from the ones that were spared that beam therapy. And so it's very important. You finish a course of radiation, and we see this as a problem also in the community with radiation therapists that don't treat a lot of MF. They will give radiation therapy, and then they'll say, okay, you're done with treatment. And that's not the way to go. The way to go is that once you're done with the radiation therapy and you have as good a response as you're going to get, whatever it is, you need to go on some follow-up therapy, usually a systemic therapy, try to maintain that response. So it's not a therapy that's a standalone therapy.
And another thing in terms of how many numbers can you have, so even in theory, if at some point you could have 2 or 3, it is important to keep in mind that the total skin electron beam is actually a strong part of the conditioning regimen going into a stem cell transplant. And you don't want to exhaust basically the number of treatments reach the maximum, because if at some point a stem cell transplant is on the horizon or really represents or presents itself as maybe the only leftover treatment, then it would not be the smartest thing to not be able to administer total skin electron beam anymore. That's why if now the answer is 2, then I think a lot of large centers would say have 1 now. The other one we keep in the backhand with maybe for a possible transplant.
This has been a great session on understanding the disease and treatments. Was there any promising studies on the cause?
Well, right now, that's one of the holy grails, is to try to figure out how this gets going in the first place. There are many lymphomas that have a particular mutation where it's pretty widely accepted that if that mutation was not there, the lymphoma would not exist. So it's very central to the disease. As I mentioned, one of the things that's striking about these advanced cases of cutaneous T-cell lymphoma is that more than 9 out of 10 of them have this a mutation in the TP53 gene. So that is a statistical clue that may be a very important mutation, but exactly how it would play its role in the whole pathogenesis of the disease is still up in the air.
Is there any research or evidence that shows that diet may increase or decrease the presence of MF?
Diet?
Diet, eat healthy, exercise.
Yeah, Only, I think, at least to my knowledge, only in the context of maintaining a healthy, well-balanced diet that, you know, agrees with your system, is going to provide general support for your immune system. And your immune system, you know, we've been talking about the therapies, things that come into your body from the outside, but part of the success of all of those therapies is your body's immune system also fighting the tumor, the MF, or whatever other type of lymphoma you might have. And so if you do things to maintain your general health and the general health of your immune system in a general way, you're helping to fight the MF. And it's, you know, things like good nutrition, adequate rest, good exercise regimen, and kind of a trying to maintain a positive mental attitude, because each of those things has been shown to affect the quality of the immune system.
I can say another word to that too, because that's one of my research interests, actually, the cancer cell metabolism. The question is, I think in 10 years, we may be able to give you a better answer. At this point, we start to begin to appreciate that cancer cells have very different fuel needs. They eat more glucose for one thing, they eat more amino acids to do another thing. But this is very, very early disease, very early research. And then, of course, with that information, it would, in theory, be possible to change diet in a way that you may be able to affect the behavior of cancer cells. So a lot of that is just done in cell culture in mice. We don't have anything in patients yet, but I'm convinced in the next 5 to 10 years, for some type of lymphoma or leukemia, we know very much what the cancer cells need to eat in order to behave aggressive. And in theory, if we took that away, and methotrexate, for example, is doing something similar, which was just published last year. So yeah, I think there may be some future there. But at this point, healthy diet in order to just increase the body's general health.
With Sezary syndrome, itch is a big symptom and a big problem because it interferes with your skin health because you're scratching, and it also interferes with your sleep. And so, but a lot of the sleep aids don't give you a complete and restful sleep. And so do you have any suggestions about how all those three things go together?
Sleep, itching, and Sezary syndrome, right? So yeah, I think it is something we struggle with, unfortunately. And oftentimes we see that if the Sezary count isn't dropping, if the skin is red, well, then the itching is also bad. If we are successfully fighting the malignant cells, the cancer cells, then also itching tends to improve. You know, other than what Dr. Glinert showed, for example, about some newer agents in the NCC guidelines, for example, naltrexone as a third-line agent to control itching. This is something we struggle with a lot in dermatology in general, because we have a lot of patients who have itchy skin. We call that pruritus. Sometimes we have no idea why, but the field of dermatology in the last, I don't know, 200 years, we just haven't found the perfect medication for that. So I think the goal is really first fighting the disease, getting that under control, and then the anti-pruritic, anti-itch medications are second line. And yeah, sleeping pills, maybe, but the data there is almost suggesting not cancer in general, but you know, that Ambien knocks you out. You're not really sleeping. Your brain is not sleeping after an Ambien. You're just unconscious. You know, that is not healthy sleep. So that can't be the solution either, to take Ambien every night and think you get good sleep. So it is a management problem.
There is actually a lot of research going on now about pruritus or itching in the skin, not just from these cutaneous lymphomas, but from all number of causes. And so it might not be too long before we have some, effective new treatments. And but don't forget about the basics, because this tends to be a disease that is mycosis fungoides tends to be a disease that hits people at the same point in life when their skin is no longer the way it used to be when they were younger anyway. It tends to be drier, and dry skin itches. And so some of the basics are keeping your skin well moisturized, not using, harsh soaps and other things in contact with your skin. And so there's a lot of little details, and you really need to, to optimize all that, you really need to sit down with people on an individual basis and find out, what they're doing with their skin, what it looks like when they come in. I think we've all seen people come in complaining about itching, and their skin is dry like the Mojave Desert. And that alone will, we see this all the time, those of us that treat people at the VA, people come in with a rip-roaring, red rash on their legs with lots of flaking and itching, and they've got scratch marks all over. And you tell them to go to the supermarket and buy a can of Crisco and put it on their legs every day, and they come back in a couple of weeks and everything's normal.
And I will also say we have some information on the website as well with regards to doing wet wraps, which can help a lot of times, especially with really itchy skin, and different just ways to try to mitigate that at home. So, and I forget exactly where it is, but it's there on the website somewhere.
Yeah, I don't know if I'm going to phrase this right, but is there any relation, with like CBCL with, I think it's neutrophil, low white blood on, what is it, neutrophina? Yeah, thank you.
So you were asking whether CTCL patients with or people with CTCL have a higher likelihood to be neutropenic, have a low neutrophil count. I'm not aware of any connection there. And if you think about sort of the hematopoietic system where the blood gets formed, even though it goes all back to one cell, but very early, the lymphocytes split off from the cells that ultimately will become the neutrophils. And at this point, we don't think it's the common progenitor where the disease sits. CTCL really sits a little bit higher in the lymphocytic line, unless there is a possible connection, and that would be significant bone marrow infiltration of by mycosis fungoides, then displacing the healthy bone marrow. But then not only the neutrophils would go down, then there would be anemia, platelets would be down as well. Yeah.
That's pretty rare. The main place that I've seen neutropenia, that is low neutrophils in your blood, in people with cutaneous T-cell lymphoma, is the ones taking interferon alpha. That can be a side effect of interferon alpha, and sometimes you have to stop the interferon alpha because their neutrophil count is getting too low. That's the main place I've seen it.
Right. I haven't seen it at all.
Okay, great. Okay, I see Sheila with her hand up.
I have a question about remission. How do you define remission? Because based on my understanding from my healthcare team, and I've heard you all mention too that it's chronic. My MF is chronic. It's going to be with me forever. So unless my understanding of what remission means, will we ever really go into remission?
The way you asked the question, I'm not able to answer that nowadays. And here's the reason why. We are just not smart enough to really figure out whether there's 1, 2, 10, 100 cancer cells in the body. It is really a question of detection limit. I can easily give you the answer, how do we define remission? And for Sezary syndrome, that would be your skin looks completely normal. Then you would have a complete remission, together with we don't find any palpable lymph nodes or no lymph nodes on a PET CT scan, and the number of Sezary cells or atypical lymphocytes in the blood is less than 250. Then the criteria for complete remission or CR would be fulfilled. Does that mean that the disease is completely wiped out? Because maybe you could still have 50,000 cells distributed all over the skin, or what about the 250 is the cutoff for the circulating disease for the leukemic cells. Some of these may be Sezary cells, yeah. But we know, how do we define these numbers? How do we define these criteria? Because we know if somebody falls below clear skin, clear lymph nodes, and clear quote-unquote blood, we know that these patients tend to do well, and we just define it because we're not smarter than that right now as kind of disease-free.
Yeah, and to expand a little bit on Dr. Scheike's point, I think if you had 250 Sezary cells, it's usually measured per cubic millimeter. That's the unit. That would equate to about 500,000 Sezary cells total in your body. So doesn't mean though that you wouldn't necessarily look good clinically, because we don't know what really tips is the tipping point where these cells are sort of held at bay. It may be that your immune system is knocking them out as fast as they can produce themselves. So there's kind of a steady state situation, and you're sort of in balance. Matter of fact, if you think about this disease spectrum, if we jump from MF over to lymphomatoid papulosis and anaplastic large cell lymphoma, the fact that the lymphomatoid papulosis lesions never get very large, and the fact that if you wait a month or 2 months, they will go away, even though new ones will come. It's sort of like that is a version of lymphoma where the host always wins and the tumor always loses. And for all we know, that may go on with other types of cancers. We don't see it because they're not on the skin where we can easily observe it. Especially with that disease, we may have sort of caught that whole kind of balance, out there on the surface for everybody to observe. And there's probably more we can learn from that whole process that we haven't been smart enough to figure out yet.